My name is Heinrich Anhold and I am the founder of StableLab. My background is that I grew up on a horse farm in Ireland with about 100 horses, and I show jumped professionally for a year after I finished school. Decided that wasn't a career for me, so I gave up and I went to college, and I studied science. I have a degree in physiology and a PhD in biochemistry, and I pretty much went straight into starting this company. So the first product that I worked on was actually a handheld blood analyzer for a complete blood count. And my aim was actually to create a horse-side blood test. I didn't start with serum amyloid A at all. I hadn't even heard of it at the time. I was trying to create a product that would be useful to vets to get instant blood results at the horse's side. And the most obvious test that it seemed we should make was a complete blood count, including white blood cells, red blood cells, hemoglobin. And in fact, we created the world's first prototype for a portable CBC. And we published 2 papers on it in Lab on Chip. We filed a number of patents. It was very successful. I was 2 years into the company at this stage. I had won Ireland's Best Emerging Company. I was one of Ireland's top 40 under 40 entrepreneurs. I met our president as one of Ireland's young business ambassadors. Things were going really well. But then I started testing this prototype in the field with our customers. And when I did that, what I realized is that the complete blood count, or white blood cells, which is mainly what people wanted from it, were not really delivering the benefit or the value that people had assumed they would. And we ran some studies, and what we showed is that it was very difficult to show the real value, or if you like, in the correlation between white blood cell count and minor clinical or subclinical problems, especially in the field. So things like minor coughs or swellings on horses' legs before a competition, when people really wanted immediate results. And it just wasn't quite coming together, and my gut feeling was that we were developing the wrong product. So I got all my investors in a room and had a very difficult discussion that we probably needed to change course. And I didn't know what we wanted to change to. We had to go and look for that. So we went to a very large racing stables in the UK, where they had a large population of thoroughbred horses, all 2 and 3 years old. All bred by the same stud, under the care of the same trainer, veterinarian, just one lab technician, and really good lab equipment. And we ran blood analysis for everything we could through that lab on those horses for about a year. And we were able to look at 24 different parameters in the blood. And what we wanted to see was, what was there other than white blood cells that might tell us when horses are sick? So the first thing we looked at was what's called general correlation, or relationship between different parameters in blood. And what we saw is that white blood cells didn't actually relate to fibrinogen, which is was the most commonly used inflammatory marker in horses. In fact, fibrinogen correlated very closely with this protein called serum amyloid A, which was the first time I'd heard of it. And interestingly, not with white blood cells, which we had expected, because we were looking originally at white blood cells and wanted to find something similar but better. And what we found was actually something different. So that was a general relationship. So whether parameters elevated or decreased, it just a general relationship between those parameters. So we said, okay, that kind of makes sense, because serum amyloid A and fibrinogen are inflammatory response proteins. And possibly we're looking at relationship between inflammatory markers, and white blood cells are possibly just immune markers. But what happens when these horses get sick? So we looked at then what's called concordance, which is like the agreement. So if correlation is like a relationship, concordance is like agreement between parameters. And again, looking at it statistically, and these are statistical values, not the actual blood values, we saw that when parameters elevated, the more they elevated, the more that fibrinogen and serum amyloid A elevated, the more they agreed with one another, but still very little agreement with white blood cells. So what we had were a subpopulation of this group of horses that had elevated fibrinogen and serum amyloid A, so they had a problem, there's something going on, and their white blood cells were going nowhere. So what this told us is that we could identify horses with problems probably in a more sensitive manner using these inflammatory markers than we could with white blood cells. This was a really big moment for us because we were now 3 years in. We had previously dropped all the work we'd done on the portable CBC analyzer, and we were trying to understand what would work better. And we had found some proteins that were elevating in horses that were sick where white blood cells were not elevating, and that was quite exciting for us. And I actually published this in a research paper in the Journal of Equine Veterinary Science in 2014. And I have to give a lot of thanks to Professor Bill Amos at the University of Cambridge, who helped us run the statistics and helped us run this study. So we still didn't understand very much about serum amyloid A at this point in time. Fibrinogen is very well characterized, and every paper we read about serum amyloid A told us that it's an acute phase inflammatory response protein. That's what it kept popping up as in the literature. So we wanted to compare it to fibrinogen to understand, well, what's the difference? Why would we use serum amyloid A instead of fibrinogen, for example? And we found 3 reasons why serum amyloid A is proving itself to be better as I guess a diagnostic or a biomarker in general in horses. So first of all, the normal level of serum amyloid A is 0 or trace. It's sub 1 microgram, which means that it's normally not present. Fibrinogen is always present, indicating that it's got other functions in the body, which can also cause it to fluctuate. Whereas serum amyloid A is only produced and is only there in response to the disease that you're basically trying to diagnose and treat. So it's more specific to an infection or to an inflammatory response in that regard than fibrinogen is. The second thing we learned about serum amyloid A is that it elevates very rapidly, and this is already known, but it's by definition a major acute phase reactant, meaning it can increase up to 1,000-fold in concentration in an inflammatory response, whereas by definition fibrinogen is a minor acute phase reactant. It can increase 5, maybe 10 max fold in response to in an inflammatory response, meaning that it's less sensitive. So we found out SA is more specific, it's normally not present, it's also more sensitive, it increases more rapidly. And then the third thing, which we're still really learning about serum amyloid A, is its half-life. Its half-life seems to be about 20 hours, under 24 hours. And the half-life of fibrinogen is about 72 hours. So it actually comes down much faster also once the inflammatory response subsides. So because it's more specific, it's more sensitive, and it disappears faster when the infection subsides. And actually, once we learned that, and we had been working on both prototypes for both serum amyloid A and fibrinogen for a stall side test for a period of time. And once we learned these things about serum amyloid A versus fibrinogen, we dropped the fibrinogen prototype and we focused entirely on serum amyloid A. Still not exactly knowing what it was doing. We were literally just following our noses and trying to create a product that would work stall side to help veterinarians understand if a horse had a problem or not. And that was the focus of our work, was to really try and create a product that would deliver that type of value and benefit. So the next study was the one that really opened our eyes. So during that racehorse study, we had about 52 cases of tying up in horses. And that was really interesting to us because every paper we read told us that serum amyloid A was an acute phase inflammatory response protein. Now here were horses with severe tying up. Some of them had CKs and ASTs into the tens of thousands, so massive elevation of the markers for tying up. Physically and clinically, you know, some of them were really set fast, found it very difficult even to move properly. So undeniable acute inflammation, yet we could not detect serum amyloid A in any of the 52 horses. So this was a real eye-opener for us because it showed us that not all kinds of inflammation were causing serum amyloid A to elevate. So the question was, well, what kinds of inflammation do cause serum amyloid A to elevate? And we ran a very simple study at Hagyard Hospital in Kentucky with Dr. Nathan Slovis. And one of the problems we encountered at this point was that all of the standards, all of the gold standards, or considered gold standards within the literature for diagnosis, were white blood cell count or fibrinogen or temperature, and we possibly had something better. So we couldn't use those as our sole basis for a control. So we decided that we were going to use Dr. Slovis's opinion as a sole basis for our control. So basically taking the opinion of an experienced practitioner, one of the best in the game, and asking him for his opinion as horses came in the door of the hospital for a diagnosis. And what we saw after about 100 cases was this very clear pattern emerge, where the horses that Dr. Slovis diagnosed with infectious conditions were highly positive for serum amyloid A, and the horses that Dr. Slovis diagnosed as non-infectious conditions were typically negative. There were a couple of exceptions. Colic is still an exception. It's an anomaly to us. Sometimes it's up and sometimes it's not, and we don't know why. And other than that, we really didn't have a lot. We saw some mild elevation in some of the non-infectious cases, but it was usually in the low tens, while infectious cases were in the hundreds or thousands. So very clear differentiation between infectious and non-infectious conditions. And this was a real breakthrough for us. We had not known that serum amyloid A could be used to distinguish. Nobody knew. In fact, there's 4,000 papers in PubMed about serum amyloid A, and until we ran this study, nobody had actually realized that it doesn't respond in all kinds of inflammation. And that was the subject of our original patent applications, the use of serum amyloid A as a biomarker to distinguish between infection and non-infection. That was the competitive advantage, and is the competitive advantage that StableLab offers, that we can differentiate between infection and non-infection using serum amyloid A. So based on that, we got very excited and we started to move forward. And what we're learning, and while we have categorized this general trend between infection and non-infection, we're trying to dig deep now and really get to grips as to what types of diseases it works best in, and where it doesn't work, and where we see false positives and false negatives. So the numbers in this table are not necessarily indicative of these diseases. These were just the cases that we had during that study. We cannot use serum amyloid A as a definitive biomarker of a specific disease. It doesn't do that. It's a non-specific biomarker. So it's typically highly elevated in infections and typically not at all present in non-infectious cases. So we know that trend very well. We don't really get false positives with it, or we haven't from the studies we've done, because it's normally not there. If it is there, something is going on. So we even think that if you see it in those non-infectious cases, there's possibly a reason for that. And it may just be that you can get a mild elevation in a very severe non-infectious case, or it may just be that there's a secondary infection happening. So we still have to get to grips with why those mild elevations are happening. We do get false negatives. In adults, so far, they've been quite rare. We see them much more often in foals. Rhodococcus is probably the main case where we see false negatives. We're still trying to understand why. There's two schools of thought on that right now. One is that certain diseases are walled off and you get either an attenuated or a no response because the infection is present but the body doesn't recognize it's present, therefore it doesn't launch the inflammatory response to attack that infection, which is where we feel serum amyloid A is produced. When the body recognizes as an infection, it stimulates a specific type of an inflammatory response against that infection, which we're calling the infectious inflammatory response. And serum amyloid A is produced as part of that infectious inflammatory response as an attack on the infection. And we think that one possibility why we might get false negatives in foals is because the body just doesn't recognize the infection, because it's walled off like in Rhodococcus, or potentially because they don't have a full immune complement. And because they don't have a full immune complement, they either don't recognize it or they just are unable to launch that response. So we still don't know exactly why, and it's something we're really digging into. So we're seeing from the data we have so far in Rhodococcus up to about 25% false negatives. And that doesn't necessarily mean that the test still doesn't deliver value for Rhodococcus. In many cases, it's the only marker that's up because nothing particularly works well in diagnosing those cases. It just means it's not, as a standalone screening tool, reliable, but it is reliable when you have a positive and you're trying to monitor response to treatment and you're trying to understand the severity of the case. So again, we wanted to try and get more detail and more understanding around serum amyloidase, so we started to map out the typical response curve for serum amyloidase. So what happens actually is a horse contracts an infection, something stimulates, or that infection somehow stimulates the production of cytokines and interleukins, and they cause the production of serum amyloid A in the liver. And SAA gets released into the bloodstream, and if you're measuring it with a diagnostic in the bloodstream, it goes from normal levels of 0 to highly elevated levels within 24 to 48 hours. It then typically plateaus and stays there until the infection subsides, and then it drops off pretty much as quickly as it goes up. There are some papers to suggest that serum amyloid A can be produced in other tissues other than the liver. And while I don't deny that they're true, I think that the vast majority must be produced in the liver, because levels can go from 0 to literally milligrams per mil after 24 hours, and I can't imagine that any other organ is producing serum amyloid A at that quantity, so that when you measure it in horse's blood you can actually get that physical quantity produced. I think the vast majority must be produced in the liver. So this is a pleuropneumonia case, and I use it just to explain a few of the points around serum amyloid A, and again this is in characterizing that response curve. So this is a horse that was transported. Post-transport it came down with pleuropneumonia, or typical shipping sickness. SA elevated within the first 24 hours, it shot up, and then it pretty much plateaued. And the horse was put on various different types of antibiotics for about 4 to 5 days, and it had a minor effect on SA. And as you can see, the response curve comes down slightly, but then the horse regressed. And we switched treatment, and when we switched treatment, it killed the infection. It knocked it right on the head, and SA was switched off. So it's like the factory is shut, SA production stops, and then it drops according to how quickly the body can get rid of it, which is about 50% every 24 hours. So in this case, SAA was used to monitor how the horse was responding to treatment for about 4 to 5 days. The treatment wasn't really working, so it was switched, and then we saw very quickly that response happened. Now, you don't always get that immediate drop-off like we see in this graph. It depends on the pharmacokinetics of your drug. I mean, you don't always find that perfect drug matched to the disease so that you can really just knock it out. But in this case it did, and you will often see this when you do find that perfect match of drug against disease. I'm often asked, quite rightly, how well does serum amyloid A compare to, in performance as a diagnostic of infections and monitoring response to treatment? How well does it compare to a thermometer? How well does it compare to a white blood cell count? And as you can see in this particular example, the horse at a normal temperature, and despite the fact that it still had consolidation in the lungs, and despite the fact that its SA was still elevated, and you can very clearly see the response to therapy. So we're trying to build out that data. We're trying to understand just how much more reliable serum amyloid A is than a white blood cell count or a thermometer. And we've compiled about 195 cases so far, 190 cases. And what we've seen is that in adults, serum amyloid A is giving us very high positive and negative predictive values for infection versus non-infection. So in other words, if you get a positive result, you can be about 90 to 95% sure that that is an infection. And then if you get a negative result, you can be over 95% sure that that is not an infection. And we still have to compile data from thermometers and from white blood cell counts, but we understand that they're much lower than that. So it does seem to be by far the most reliable indicator for distinguishing between infection and non-infection. Okay, so these are the ways in which people are actually using the StableLab product. And I think this is quite interesting, because when I started selling the test originally, people assume because it's a blood test it should go with all other blood equipment, and actually that's not what we set out to do with this product in the first place. We wanted something stall site, so used at the horse's side. And if you really think about that, that's much more close to how you would use a thermometer than it is to how you would use traditional lab testing. So what StableLab does actually is it introduces something that's used like a thermometer, but it's more reliable than a thermometer. So kind of like how ultrasound is a better version of a stethoscope, the StableLab handheld test is designed to be a better version of your thermometer. And then after running it, you can decide whether you really want to send to the lab for further diagnostics. You've got to steer as to what it is you're trying to look for. So the way that people use it is to monitor response to antibiotics. That's actually the single biggest use case for the product, and it's the most reliable way to use it, because if you already have a positive result for serum amyloid A and you know it's there, you know your horse is sick, you're literally just treating and watching for that drop off of serum amyloid A to understand how well the treatment is working. People regularly ask me what levels of serum amyloid A matter, at what point should I become worried? And while we do have some guideline numbers, there's no real hard and fast rules apart from the fact that it should not be there at all. So if it's there, something is happening. Now, typically speaking, under 50 is clinically irrelevant. Between 50 and 200, you should start to become, I guess, more proactive, maybe in further diagnostics to really understand what's happening with the horse. And above 200, as a rule of thumb, the horse is typically clinical and requiring treatment, but not always. What's actually more important than those numbers is the rate at which SAA is elevating or dropping. If it's elevating very rapidly, then you have a serious problem on your hands. And if it's dropping very quickly, then you know you've got a grip on the problem. So what we always advise, rather than just taking the number as an absolute, always use it in conjunction with your clinical opinion. This is a clinical diagnostics tool. It's not a standalone diagnostic. Like, you would never use your thermometer just on its own. So always use it with your clinical judgment and look for that rate of elevation or rate of drop. The second way in which people are using the test is to confirm an infection. So some of the most common cases for us, respiratory cases, has to be number one, a coughing horse. Is that an infection, or is that just an allergy or an irritation? And serum amyloid A is proving to be very reliable in respiratory cases in particular, or seems to be proving that is probably the most effective way to use it. What we often see is that horses might have mucus and still no SAA, and where we think it's proving to be one of the most valuable places in the industry is in that regard, that exact regard, because horses can have mucus either post-infection, so the active infection is actually cleared and mucus is residual, or the mucus can be caused by something that's not related to an infection. It can just be an allergy or an irritation. And we're actually reducing the amount of antibiotics used unnecessarily in that regard. And we've seen quite a big shift for many veterinarians in that area, because they're just diagnosing their horses differently and they're using much less antibiotics for those respiratory cases. And we're very proud of that, because we understand what a major issue it is with the overprescription of antibiotics. The other area where we confirm infections versus non-infections, where it's proving really useful, is like in cellulitis and soft tissue cases, so swelling in a limb. Does that necessarily mean that the horse is an infection, or is it soft tissue injury or a joint flare post-infection? It's proving to work well on both synovial fluid and peripheral blood. We still have to really nail the protocol on that, so right now we're recommending to use peripheral blood in parallel with synovial fluid, and to continue to use it for a day or two, because we still don't know if the elevation happens initially in the joint or in the blood. And then the third area where serum amyloid A is proving particularly useful is in screening for infections. And that is where people are actually developing protocols for how to use serum amyloid A in a very controlled manner. So for example, breeding farms. We've just released a paper on screening newborns the same time as IgG, and we've shown that serum amyloid A is actually 3 times more reliable than a white blood cell count or an IgG at distinguishing healthy versus non-healthy foals at under 12 hours. So What we found difficult at the start was to convince the breeding farms to actually use it because they saw it as an additional cost. But once we agreed a protocol with the breeding farm where they saw it as an investment for the whole breeding season, at the end of the season they could really see the return, because there's always a handful of cases where they said if we hadn't have had that test, we would not have managed that case so well, and who knows where it would have ended up. So we find these protocols very useful in these more commercial applications, or indeed I guess in cases where people are competing regularly post shipping, so testing the horses 24 to 48 hours after they arrive at an event. Again, we ran a study recently in conjunction with US Quarantine. The United States Department of Agriculture were very kind to let us do that, and what we saw is that serum amyloid A was more reliable than a thermometer at detecting shipping sickness. So a fever did not always mean that the horse was sick, but serum amyloid A did. And we did that screening 48 hours after the horses arrived at a facility. The other main screening area is in pre-surgical screening. So sometimes surgeons, even if they have a questionable white blood cell count and the serum amyloid A is negative, they're still electing to go to surgery, and the results so far have been good on that, or they've been reported back to us as being very positive on that. So we're at this point where we understand the general trend between infectious and non-infectious cases, that serum amyloid A is highly positive in infectious cases and typically negative in non-infectious cases. We know the response curve of serum amyloid A elevates, is typically 0, elevates within the first 24 to 48 hours of an infection, stays elevated and plateaus until the infection clears and then drops off. And then the third thing we're starting to learn about it is how to really use it. So monitoring for response to antibiotics, distinguishing between an infection and non-infection, and screening for infections. We've also learned that SAA is more reliable in adults than foals, so a very high positive predictive and negative predictive value in adults. We're getting up to 25% false negatives in rhodococcus cases, but it's still proving a very reliable screening tool, 3 times more reliable than white blood cells in foals. So we just have to pinpoint exactly how to use it in foals, and we also have to pinpoint how it works with specific diseases, and that's the next phase for where we're getting with it. So that's our general understanding of serum amyloid A to date. We'd be happy to receive any questions via our website, and thank you for watching.